MashaAllah, people are joining very well. We'll give them a couple of minutes to join more, inshallah.
And I thought it's not working.
No, 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 it is weird. I can see you and I can hear you. I've reached close to 500 now. So, MashaAllah. Assalamu alaikum, Jamia, good evening. Um, I am very pleased to be with you tonight with a dear colleague and friend, senior interventional cardiologist, Hussein Amri, well known, I'm pretty sure, to all of you, to talk about a very nice and important topic, which I'm pretty sure many of us have been involved in recently, the role of the cardiologist in reducing diabetes-driven risk. Recently, and as you all know, we have been more involved in diabetes care, especially because of the new medications, but also because of the strong correlation between diabetes and cardiovascular diseases and outcomes. Um, Diabetes is an issue in our region and in our kingdom. We have high incidence or high prevalence of diabetes actually with its complications. It's probably one of the highest risk factors for cardiovascular disease. I think it deserves more and more attention. And thankfully, and thank God for the new medications and new therapies that we have that prevents cardiovascular outcomes of diabetes and is beneficial for both the heart and kidney in our diabetic population. Um, I will start by a short uh, talk and introduction just to open the uh, floor for then for Dr. Hussein to lead for the main talk. Um, are my slides clear?
Yes, they are.
Excellent. So um, I'm Walid Al Habib. I'm a heart failure adult cardiologist at Kingside University Al Habib Medical Group, and it's a real uh, uh, pleasure to talk about this important topic. And as you all know, cardiovascular disease is the most common cause of death in people with type 2 diabetes. Actually, it's the most common cause of death, full stop. In Saudi Arabia, it reaches up to 40% of the causes of death. But diabetes per se has a growing global incidence, about 536 million people affected with diabetes as a statistics in 2021, projected to increase to 783 million by 2045. So that's a 46% increase. Um, Nearly 1 in 3 people with type 2 diabetes have cardiovascular disease. 9 out of the 10 are atherosclerotic cardiovascular disease. Of course, the 1 out of 10 is heart failure, although I do believe heart failure is still higher as well. Um, Cardiovascular disease will account for around half of the deaths of patients with type 2 diabetes. So there's no doubt that the correlation between them both is very high. There's a lot of common modifiable risk factors between diabetes and atherosclerosis. Many of our patients live the sedentary life. They smoke. They have dyslipidemia. Obesity is on the rise, and they are hypertensive as well. Collectively, with diabetes in the background, this increases significantly cardiovascular disease and cardiovascular mortality and morbidity. The guidelines have touched on that very well, and I also advise you to look at our Saudi Heart Association position statement on diabetes and cardiovascular disease and the role that we cardiologists should have in managing diabetic patients. If you recall, in through history, initially the interest was in diabetes management was all about glycemic control. It was about HbA1c. Nevertheless, they were never so keen about reducing the HbA1c too low, below 7, because of the risk of hypoglycemia with the older medications. Now, with some of the medications that showed worse cardiovascular outcomes, actually, some of the medications, if you recall, showed bad uh, uh, cardiovascular disease or cardiac mortality. The mandate was to have a medication that is cardiac safe, was safe to the heart. Luckily, we didn't just find medications that were safe to the heart. We found medications that were beneficial for the heart as well, like SGLT2 inhibitors. You remember the empagliflozin trials and the dapagliflozin trials, which proved cardiovascular disease a benefit. And then further studies were not just focusing on glycemic control, they were also focusing on atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease outcome in the GLP-1 receptor agonists, showing the benefit for both cardiovascular disease and chronic kidney disease, and SGLT2 inhibitors, focusing mostly on heart failure and also chronic kidney disease, and making the guidelines move from the glycemic approach control into outcome benefit and combination of outcome benefiting medications, independent of the baseline, which used to be metformin. So now this is one of the major guidelines that have looked at it, the ESC and the ACC guidelines, the American Diabetes Association guidelines. All of them were goal oriented. So if you had a patient with cardiovascular disease, let me focus this more. If you had a patient with type 2 diabetes and atherosclerotic cardiovascular disease, or indicators of high cardiovascular disease risk, then you should consider starting with the GLP-1 receptor agonist with proven cardiovascular benefit, or SGLT2 inhibitors with proven cardiovascular disease benefit, or combining them both if your HbA1c goal has not been achieved to start with. If the main risk was heart failure, as you all know, SGLT2 inhibitors probably have the upper hand in this. Nevertheless, if your patient is still uncontrolled, your second line is combining with a GLP-1 receptor agonist. So as with chronic kidney disease patients, SGLT2 inhibitors and or combining with GLP-1 receptor agonists. So the baseline is having both these classes of medications with proven cardiovascular outcomes to improve on patients. Many guidelines, as you can see, whether it's the American Diabetes Association, European Society of Cardiology, American College of Cardiology, American Heart Association, all of them touched on that and pushed for it very clearly. Even peripheral artery disease, peripheral aortic and aortic disease, and please don't forget that patients with peripheral artery disease or aortic disease are considered cardiovascular disease patients and should be targeted as well with medications with cardiovascular disease benefits. Um, Recently, and even from before, but recently, more focus has been on metabolic syndrome and metabolic disorders. The basis of this is usually obesity with multi-organ disease involvement. It will involve the heart, the vessels, the kidney, the liver, and the pancreas. And it has been staged depending on the complexity of the disease, and the worse the stage it is, the more the events occur. We have a strong role as healthcare practitioners and providers to focus on metabolic syndrome and metabolic disorders. We have to look into the causes of it very clearly. As I said, obesity is the center of it. That's why it is a disease by itself and should be a focus of management. Lots of medications, thank God, are more available for these patients, and a lot of public health policies need to be changed to take this into considerations. Um, Now, when you as a clinician guide your management of metabolic disorders and their sequelae, this is a very nice paper from the European Atherosclerosis Society looking at all these um, all these disorders, um, including type 2 diabetes, the diastolic dysfunction, MASH, chronic kidney disease, subclinical atherosclerosis. All these are the basis of disorders that are happening with in patients with obesity or metabolic syndrome, leading eventually to heart failure with preserved ejection fraction, mainly. It can even lead to heart failure with reduced ejection fraction, cirrhosis of liver failure because of the fibrosis and fatty liver, reduced kidney function, kidney failure, even atherosclerotic cardiovascular disease. And the focus is on the management of each one. It's not the focus of the talk today, but as I said, if you focus on each one of these metabolic disorders, you will be able to prevent the complications. And again, obesity is probably the core of all this and a big part of it. And that's why we need to have it as a goal in our management. Don't forget that the GLP-1 receptor agonist and GIP receptor agonists are key in the management um, of obesity. Nevertheless, we should choose the ones with the cardiovascular, proven cardiovascular disease outcomes. With that, I would like to stop here um, uh, and move the mic to my dear colleague, Dr. Hussein Al-Amri, who will talk to us about updates in semaglutide cardiovascular outcome trials for type 2 diabetes and high risk and established cardiovascular disease patients. So please, Dr. Al-Amri.
Thank you, Dr. Walid. I'm honored to share this session with you, and I'm honored to be with the audience. We know that type 2 diabetes is characterized by hyperglycemia, and it's associated with very high cardiovascular risk. It's actually one of the major risk factors, and most of our patients with cardiac disease and with complications. They have diabetes or obesity or chronic kidney disease. Managing glycemia is critically important. However, reducing the risk of cardiovascular disease and outcome in these patients is as equally as important as reducing diabetes and its complication. If we look at GLP-1 receptor antagonists, what are they? They are a class of medications that mimic incretin hormone, which is a glucagon-like peptide. It's secreted from the gut as a result of food intake and stimulates insulin, along with hyperglycemia. Semaglutide resemble GLP-1 by 94%. GLP-1 antagonists or agonists, sorry, they have multimodality effect. They lower the blood glucose, reduce the weight, they protect the cardiovascular system, reduce MACE, they have renal protection, and they have anti-inflammatory and anti-atherosclerotic effect, along with neuroprotection, along with the glycemic control, lipid improvement, blood pressure. So it has an extensive and comprehensive cardio, kidney, and metabolic effect, which makes it very valuable in a comprehensive metabolic disease management. If we look, how does it work? It acts almost in every system in the body positively. In the heart, it improves contractility, LV function, improve myocyte survival, it's cardioprotective, improve glucose metabolism, it causes vasodilatation, and so on. The same in pancreas, it improves insulin secretion and decreased glucagon secretion, improves satiety also in the GIT and in the brain. It has positive effect in the kidney, brain, adipose tissue, muscle, bone, liver, and also on the vascular structure. So it positively affects every organ in the body, which really contributes to its comprehensive and multi-modality action. So the net beneficial effect of these receptor antagonists encompass multiple cardiovascular, metabolic, and organ-specific benefit that collectively improves overall health, especially in individuals with type 2 diabetes and at high or with cardiovascular risk. If we look, what's the mechanism of anti-atherogenic effect of GLP-1 receptor agonists? First, they improve the endothelial function by vasodilatation and also by increasing nitric oxide. It has extensive anti-inflammatory action. It reduces the inflammatory markers in the body, which stabilize plaque and reduces inflammation in the body and also in the vascular system and in the blood vessel. It reduces oxidative stress. It has positive effect on lipid profile and also on vascular remodeling. All of these along with weight loss and metabolic effects, especially hemoglobin A1C and blood pressure. So in general, they combat atherosclerosis through multiple mechanisms, improving endothelial function, reducing vascular inflammation and oxidative stress, modifying plaque profile, stabilizing plaque, and promoting healthier vascular remodeling. These actions collectively confer anti-atherogenic effect that decreases the risk of ischemic cardiovascular events. This is important to understand the outcomes in the trial. How did we achieve such outcome with GLP-1 receptors agonists? So if we look at the effect, it's on the heart and on the blood vessels, it's extensive, including inflammation, ischemic injury, improving glucose uptake, improving LV function, myocardial contractility, decreasing inflammation, improving blood flow, etc. So it has extensive effect, positive effect on the heart and on the vascular system, and the net benefit is cardiovascular reduction, better glycemic control, better weight loss, better blood pressure control and reduction. It protects the organs, including the kidney, the pancreas, the liver, the heart, the brain, the muscles, etc. It also has anti-inflammatory and anti-atherosclerotic effect, along with the neuroprotective effect. And if we look at the evidence is extensive from multiple trials that included different GLP-1 RAS drugs. However, why did we pick, and meta-analysis of these trials shows extensive and significant benefit in MACE with 14% reduction, 13% reduction in cardiovascular death, 12% reduction in all-cause mortality, non-fatal MI by 10%, stroke by 17%, heart failure by 11%, and renal progression to end stage or renal disease by 21%, which is the most significant. However, why did we pick semaglutide? It's the most extensively studied drug in diabetes and non-diabetics, in obesity, in patients with kidney disease, and it has the highest and the best outcome and the most significant reduction in MACE, as in SUSTAIN 6, where there is 26% reduction with MACE, and in MACE, and in PIONEER there was 21% reduction in MACE, which is more significant than any other GLP-1 receptor agonist. If we look at SUSTAIN 6, which was the first trial, it was performed in patients with diabetes at high risk for cardiovascular events, and they were randomized to 0.5 or 1 milligram or matching placebo, and they were followed up for 2.1 years. The primary composite outcome was death from cardiovascular cause, non-fatal myocardial infarction, or non-fatal stroke. And at around 2 years, there was 26% reduction in MACE in patients who are receiving semaglutide compared to placebo. And the number needed to treat to prevent one cardiovascular event was only 45 patients at 2 years, which is very significant in these patients. The MACE reduction was not only significant for these three, the collective primary endpoint, but also it was for the individual endpoints like non-fatal stroke, which was reduced by almost 40%, which is significant. And we know that stroke is a disabling disease that really affects the quality of life. Again, worsening nephropathy was reduced by 36%, and revascularization, either carotid, coronary, or peripheral vascularization, was reduced by 35%. MI was reduced by 26%, which is significant, non-significant, because probably the study was not powered for that. This benefit was with very or no side effects or side effects are less than placebo, apart from nausea and some GIT upset, which is related to delayed gastric emptying. However, there was no significant increase in serious adverse events. Rather, there was reduction in infection in these patients, probably due to improvement in the metabolic factors, especially hemoglobin A1C. Then PIONEER 6 came after that, and they studied the oral type of semaglutide in patients more than 50 years with type 2 diabetes. But in these patients, they had established cardiovascular disease or kidney disease. So they are higher risk than SUSTAIN 6 trial. And the primary endpoint was death from cardiovascular cause, non-fatal myocardial infarction, and non-fatal stroke, along with other supportive endpoint. And again, it showed significant 21% reduction in MACE with oral semaglutide. However, the study was underpowered for superiority. So semaglutide was not inferior, but because of the small number of patients in the trial, it was underpowered for superiority. So both SUSTAIN and PIONEER provide an extensive data on semaglutide glycemic, weight, cardiovascular, and renal benefits in type 2 diabetes, and they established the basis of recommendation of semaglutide in such patients. Recently, last year, SOUL trial was published, which again looked at oral semaglutide in patients with type 2 diabetes with cardiovascular disease or chronic kidney disease. and the inclusion were age more than 50 with diabetes, hemoglobin A1C more than 6.5, with at least one of the following conditions: coronary artery disease, cerebrovascular disease, peripheral artery disease, or chronic kidney disease. And the primary outcome was cardiovascular death, non-fatal MI, and non-fatal stroke. Again, it showed significant 14% reduction in MACE in patients receiving oral semaglutide. If we look also at all supportive endpoints, either primary or secondary, they were significantly reduced with oral semaglutide, especially death from kidney causes. So a summary of the trial is that the MACE was reduced, expanded MACE was reduced by 16%. Again, non-fatal MI by 26%, which was significant, and coronary revascularization was reduced by 25%, along with better hemoglobin A1C control, more weight reduction up to 13%, and better inflammatory markers compared to placebo. Hemoglobin A1C reduction was significant, BMI also was significant, and the high sensitivity C-reactive protein reduction was significant with semaglutide. All of this, again, comes with very high safety profile in these patients. And the number needed to treat with oral semaglutide is only 50 to prevent one major cardiovascular event, which is really significant at 3 years. So the conclusion of the trial that among patients with diabetes and atherosclerotic cardiovascular disease or chronic kidney disease or both, the use of oral semaglutide was associated with significantly lower risk of major adverse cardiovascular events than placebo without increasing the incidence of serious adverse events. Remember that the benefit in these patients is on top of standard of care, which means statins, ACE inhibitors, diabetic insulin, or other diabetic medications, including SGLT2 inhibitors, and so on. So the benefit comes on top of all, or the standard of care, or the guideline-directed medical therapy. So if we look at the key trials, they include SUSTAIN, PIONEER, which are in patients with diabetes and high or with cardiovascular disease or chronic kidney disease. SOL, again, in patients with type 2 diabetes and high risk, with cardiovascular disease. However, SELECT was performed in patients without diabetes or with hemoglobin A1C less than 6.5 or pre-diabetics. And again, it showed 20% reduction in MACE in these patients. So even if a patient is not diabetic, but he has overweight and cardiovascular disease, there's significant reduction in MACE in these patients when they are treated with semaglutide. Finally, recently, probably 2 months ago, the FLOAT trial came out, and this trial was in patients with chronic kidney disease to see, and type 2 diabetes, to see the effect of semaglutide on progression of kidney disease and reduction or improving the cardiac outcome in these patients. And the outcome was amazing, with 24% reduction in the kidney outcome, which includes decline in GFR, kidney or cardiovascular death, which is significant. Again, MACE, which is cardiovascular death, non-fatal MI, or stroke was reduced by 18%. All-cause death was reduced by 20%. Cardiovascular death by around 30%. Heart failure or hospitalization or progression or cardiovascular death due to heart failure was reduced by 27%. Heart failure alone, again, 27%. And cardiac death alone is 29%. So there was significant reduction in patients with chronic kidney disease and cardiovascular disease, and at high risk, who are at high risk for cardiovascular disease, significant reduction in all the endpoints of MACE. And the conclusion that semaglutide reduced the risk of clinically important kidney outcome and death from cardiovascular disease in patients with type 2 diabetes and chronic kidney disease. So what's the comprehensive effect or the multimodal effect of semaglutide? It has significant reduction in MACE in patients with cardiovascular disease, also in patients with type 2 diabetes and heart failure, as was shown in in STIB HIF-BIF and in STIB HIF-BIF diabetes. Again, in FLOW trial, there was 27% reduction in cardiovascular events. Also, in patients with chronic kidney disease and type 2 diabetes, FLOW trial, there was significant reduction in cardiovascular outcome. The kidney outcome, there was significant reduction in progression to chronic kidney disease. And obesity or overweight and high cardiovascular risk, SELECT trial showed significant reduction in MACE in patients without diabetes or who are pre-diabetics. Semaglutide results in significant weight loss, and also it alters the body composition, especially the waist. There's significant reduction in waistline, which is, as we know, or circumflex, which is, we know that it's related to MACE and high events. It results in better glycemic control. Again, it has antidepressant effect, improve cognitive function, and decrease hunger sensation or through hypothalamic effect. It has significant metabolic on levels and hemoglobin A1C and inflammatory effect in the body. It improves the quality of life and the function, the physical function. All of this is independent of the baseline medications of the patient. And the clinical implication is that we can use semaglutide now in patients with established cardiovascular disease, whether they are diabetics or not diabetics. Those also who have high cardiovascular risk, whether they are diabetic or not diabetic, patients with obesity and cardiovascular disease, or obesity and high risk for cardiovascular disease, as in SELECT trial, and patients with chronic kidney disease, whether they have or they don't have established cardiovascular disease. And again, the benefit is independent of the baseline medication that the patient is receiving. This extensive evidence was reflected on the recent guidelines. If we look at the latest AC chronic coronary syndrome guidelines, semaglutide, use of semaglutide to reduce cardiovascular event in type 2 diabetes and atherosclerotic cardiovascular disease is class 1 level of evidence A. And also the same for the AHA-ACC, the use of semaglutide to reduce MACE in type 2 diabetes with atherosclerotic cardiovascular disease is class 1 level of evidence A. So in summary, GLP-1 receptor agonists provide holistic approach to patients with type 2 diabetes and obesity alone, chronic kidney disease, heart failure with preserved ejection fraction, or those at high cardiovascular risk or with established cardiovascular risk. The evidence that we have comes from trials with injectable and with oral semaglutide. So what's our next job? What should we do next? How should we approach this evidence? I think the best is that each center or each hospital should have a cardiometabolic and kidney clinic to combat cardiovascular risk in diabetics and also in non-diabetics who are at high risk or with cardiovascular disease. Actually, we are working with Novo Nordisk to establish a clinic. Hopefully within a month we will do that, to start semaglutide treatment in our patients who are either with or at high risk of cardiovascular disease, who are obese or overweight, or they have metabolic syndrome, diabetics, and those with chronic kidney disease. And I hope that we can really make a registry for these patients between all of our centers and hospitals, Kingdom or even Gulf wide, with the help of the Novo Nordisk company. Thank you, Dr. Walid, and thank you for the audience.
Thank you very much, Dr. Hussein, for this very thorough and amazing overview of the evidence. I think you made it quite clear. Someone probably rushed asking a question before you went through the data. Did semaglutide have reduction in cardiovascular disease events, and I think you showed that very, very clearly in many of the trials. Let me take some of the questions. I'll start probably with the first one. Someone is asking about the obesity is a very important risk factor, but what's the role of lifestyle? Now, there is no doubt that lifestyle is the baseline. We ask all our patients to start and have lifestyle modifications, including diet and exercise and the type of food and the time of food and things like that. But you probably know the failure rate is quite high, and that's why many of our patients will end up needing either medications and therapies or even surgeries, including sleeve and bariatric surgery. So lifestyle is the core, but having things to help is quite important as well. There is a question, although it's probably not totally related, but maybe Dr. Hussein, someone is asking about beta blockers and in diabetic patients. Is there a risk of using beta blockers? We use them all the time. Do you have any precautions when you use it on your patients?
I think most of the beta blockers we use are cardioselective now and with little effect on the peripheries or on hypoglycemia or the sensation of hypoglycemia. So I don't think there's a risk. We use it almost in every patient with diabetes and cardiovascular disease. So there's no concern of beta blocker in patients with diabetes because they are highly cardioselective.
That is true. A question about the combination of SGLT2 inhibitors and GLP-1 agonists in patients with established cardiovascular disease. Although we touched briefly on that, would you like to take Dr. Hussein, when you have a patient with established cardiovascular disease, how do you usually approach it between SGLT2 inhibitors and GLP-1 agonists?
Actually, the mechanism of action and the benefit of each is different. SGL2 are mainly protects the cardiac muscle or cardioprotective, and they are beneficial in patients with heart failure. However, they don't have significant anti-inflammatory, anti-atherosclerotic, or plaque stabilization effects. So the mechanism of action of each is different. I'm not really aware of whether there is a study that comparing both. However, we know that in all the trials we mentioned, up to 26% or 27% of these patients, they are on SGLT2 inhibitors. So they are, synergistic in effect, and both of them, they improve outcome. But if we look at SGL2, it's mainly, the benefit is mainly in patients with heart failure. However, the GLP-1 inhibitors, the benefit is in heart failure with preserved ejection fraction, in patients with cardiovascular disease, and in patients at risk of cardiovascular disease, whether they are diabetic or not diabetic, whether they have kidney disease or not, and those with obesity. Probably the sponsor can answer whether there is a study in the pipeline comparing both together, but I'm not aware of that.
Yeah, I agree with you. Yeah, and as you mentioned, if it's more of heart failure and kidney disease, the plethora of data is more with the SGLT2 inhibitors. If it's atherosclerotic cardiovascular disease, then more with GLP-1 receptor agonists. But nevertheless, combining both together will probably add the benefit in our patients, especially in obese patients and patients who are at risk of both. One was suggesting now having oral GLP-1 agonists. Why, or is there any intention to have them both in one drug, in a combination of oral semaglutide with oral SGLT2 inhibitors? I'm not sure if that's manufacturally possible.
Actually, Walid, the suggestion of comparison between GLP-1 and SGL2 inhibitors or the combination of both is really a very smart and good question. Probably we can start a study in our patients, since most of our cardiac patients, up to 60%, are diabetics. I think it's a very good subject for study in our population if we can initiate that as a multi-center study, and then probably they can sponsor that, the company.
Yeah, I think it's a very good
Brilliant
idea. I
question.
agree
Thank
with
you.
you. Yeah. Now, of course, there is someone is asking about SGLT1 and SGLT2 in cardiovascular disease. Of course, there's the new sotagliflozin, which was positive and is coming recently, and will be it's FDA approved, will be coming recently to the or soon to our market as well. But we don't have lots of evidence, data about it or experience uh, about it yet. Um, Now, someone is asking about the role of genetics versus other risk factors, typical risk factors like smoking, hypertension, obesity in cardiovascular disease. Dr. Hussein, how much does genetics play a role in our cardiovascular disease patients versus the classic or typical risk factors?
I think all diseases are related to genes, and I think uh, if you don't have genetic susceptibility to diseases, probably these risk factors won't affect you like patients who are susceptible to such a disease. So genetic factors are very important, and I think it's the major factor in cardiovascular disease, in diabetes, in cancer, in hypertension, in almost every disease. So definitely genetic factors and history of or family history plays a major role in these patients.
That is true. Semaglutide in pregnancy, I think, well, we know that semaglutide is contraindicated in pregnancy. It can cause, it's potentially harmful for the fetus, and it's not recommended in pregnancy. Um, people keep
If
on
we
asking
notice
about the
most,
company. Yes, go ahead.
if we notice most of the patients who are included in the trials are more than 50, whether male or female. So really, pregnancy is not really well studied for semaglutide, and we know that most, healthy women in general at childbearing age, they are at low risk of cardiovascular disease, except few of them who have diabetes.
Um, Well, many of our most of the patients who use semaglutide in our community are actually the young, and they use it for obesity and weight
Wait,
management. We've seen that, but I think if they're going to get pregnant, they should stop. Now, one thing I was surprised when you mentioned, and it took my attention. You said it has antidepressant effect, although there were some reports that it increases depression. Um,
maybe it's contradicting reports, but in general, it improves the neurocognitive function uh, by improving, glucose and fat metabolism in the brain. It has a potential neuroprotective effect, including the cognitive function. Of course, this to be proved. I'm sure soon we will see studies about that.
yeah. I think one of the reasons is it inhibits your appetite. So some people with the inhibition of their appetite, some nausea that can happen. Some of the classic side effects, it can give you some mood disturbances, and we've seen that in some of our patients. In your practice, how many of your patients um, couldn't tolerate the semaglutide because of the side effects?
Actually, less than 10% they cannot tolerate it. Most of the patients, they are dedicated to lose weight and to look healthier. And I believe, the probably antidepressant effect comes from self-satisfaction. When you lose weight, you look nicer, you look healthier, you look younger, and you become more fit. So your satisfaction about your image is really is an antidepressant effect. Probably this is the major factor in as an antidepressant. But we know that probably in studies, up to 20% or even more they stop the medication because of intolerance. Uh, However, it's mainly due to minor gastric upset, and these patients probably they are not really dedicated for the risk reduction or the weight reduction.
Now, I like this question, and it's very important. I think it will help the one coming because I had a very strong argument, unfortunately, with the insurance company a couple of weeks ago. Um, the question is, can we combine GLP-1 receptor agonists with insulin?
Of
Patients who
course,
are
because in the studies it was combined with insulin.
exactly. Now, unfortunately, it's a misconception, even with the insurance companies, that if a patient is on insulin, that's it. He cannot take anything else. And I was in a long argument, in I just couldn't convince them. I know it was financially driven, but of course, it's a medication. It has no contraindication with insulin. It's on top of other medications, as you mentioned, their studies, and it still maintained its benefit with blood sugar reduction and in cardiovascular outcomes. That's a very nice one. Um, Now, GLP-1 any role in pre-diabetes with BMI more than 35 in obese patients who are pre-diabetics. Do we have any evidence or studies on them?
Yeah, actually, Select Trial looked at that. Select Trial looked at patients pre-diabetics or no diabetes. And by the way, it's probably the largest study ever made. It's more than 17,000 patients. Uh, these patients were either overweight with BMI more than 27 or obese with different classes of obesity. And they had hemoglobin A1C less than 6.5, so they were not diabetics. But 80% probably they had some hemoglobin A1C between 5.7 and 6.5. So majority were pre-diabetic. And there was significant reduction up to 20% in MACE in these patients, along with reduction in MI, stroke, kidney progression to kidney disease, and almost 80% reduction in progression to diabetes. So we have the evidence also in patients who are obese or overweight without diabetes, who are at high risk or with established cardiovascular risk from Select Trial.
Dosing. Someone has asked about the dosing of semaglutide. Classically, it starts from zero point 0.5 milligram now up to 2.54 milligram for obesity. For diabetes, it's 0.5, 0.25, sorry, 0.25, 0.5, 0.75, 1 for diabetes, and then 1.5 and 2.44 for obesity. It's an increment usually over 2 to 4 weeks for these patients. Doctor, many of these medications have been um, implicated in increase in heart rate. How much is that a problem in GLP-1 agonists?
Actually, this is very well known that it increases heart rate, and probably this is one of the mechanisms that also it increases the metabolic rate. However, it's really not clinically relevant or does not cause problems in these patients. Remember that all GLP-1, they affect the brown fat, and they increase the metabolism and the heat in brown fat, and it increases the lipolysis of brown fat. And part of this increased metabolic component is the increase in heart rate. But it's very well noticed, and it was in the third slide that the cardiovascular effect, it increases heart rate.
Yes, I agree with you.
But it's not clinically relevant or concern.
Exactly. We rarely see it in practice. I mean, some patients complain of some tachycardia, but it's not very disturbing. Um, and this is a question that we always get asked about our patients. How long can I continue the medication? How can I continue semaglutide injections?
I think as long as
life.
up to 5 years now, we have evidence from trials of safety up to 5 years.
Yeah.
Probably
It's a life medication. It's a life
exactly.
medication, especially if you're diabetic. And now with the strong evidence in cardiovascular and kidney protection, I think it's a live medication and shouldn't worry people about.
I think one concern that anyone who uses semaglutide or any GLP-1 agonist in these patients is to look at retinopathy, because in the flow trial there was uh, some concern about retinopathy in these patients. We don't know whether it's due to the medicine itself or due to the disease itself. So probably frequent ophthalmological examination is required in patients who are on semaglutide with diabetes.
And I think there were lots of talks about it, but the small study wasn't really randomized, and it was
Yeah.
just a report from one hospital, and it wasn't very strong. The other thing that you reminded me of is that if these medications they reduce weight, they affect the whole body. It's very important to maintain and exercise and a strengthening regime, not to lose muscle as well, because you don't just lose fat when you take semaglutide. So that's very important for patients as well.
But remember that
Yes.
lifestyle modification was never successful in reducing cardiovascular events or outcome. There's only two treatments, GLP-1 and, I mean, obesity-wise, GLP-1 and bariatric surgery. These are the only two treatments that can improve outcome in patients with diabetes or with obesity. Lifestyle modification is definitely important, some exercise and so on, and it's part of the standard of care of any patient who's cardiac, diabetic, or any other disease, but it won't reduce the events in these patients.
There's a question here. Do you think it's a class effect for all GLP-1 receptor agonists, or it is medication effect?
No, it is a class effect, definitely, because liraglutide and all the medications in different trials were effective in reducing MACE, but most of them were less than 16 or 17%. The only one that was very effective, more than 21%, is semaglutide. That's why probably it gained popularity among us to be used in patients with diabetes or obesity and cardiovascular disease.
Nice. Again, a question about insulin and GLP-1 receptor agonists. It's like combining any medications. You have to watch out for blood sugar. If the patient starts improving and dropping the blood sugar, you may be able to reduce insulin dose to avoid hypoglycemia. But as we all know, insulin is just a glycemic control medication. I'm not going to go into the postulated theories that it might be even harmful, but the least that it does not have any outcome benefit. So if you can switch or reduce your doses because of the use of other medication, GLP-1 agonists, then you should be able to do that, and it would be beneficial.
If you allow me,
Um, yes, Fadl.
this is a very important question. We have to remember that GLP-1, they do not work unless there's hyperglycemia. If we look at insulin or oral hypoglycemic drugs, they reduce glucose regardless, whether the level is low or not. So let's look at the oral hypoglycemics. If you take them, then it will decrease the glucose. It will induce or stimulate insulin secretion, whether the glucose is 400 or 40. So that's the cause of hypoglycemia. While GLP-1 inhibitors, they work only if there is hyperglycemia. When there's no hyperglycemia, they don't work and they don't cause hypoglycemia. And if you notice, hypoglycemia is not one of the side effects of GLP-1 agonists. However, as you mentioned wisely, we have always to be careful when we combine anti-diabetic medications to avoid hypoglycemia. So the mechanism of action of in patients on GLP-1 inhibitors works only if there is hyperglycemia or food intake.
Very nice. Do we have any comparison between semaglutide and tirzepatide? Always asked.
I really don't have
Yeah.
an answer
So
for
yeah,
that. Probably one of the company can answer, but I don't
no,
think
I can
trials
tell you
together.
that classically tirzepatide is probably a little bit more potent in the studies, but we still don't have cardiovascular outcomes with tirzepatide. Our cardiovascular outcomes are well established with semaglutide. We don't have head-to-head comparison between both. They are both good weight reduction medications in and anti-diabetic medications in our diabetes populations. But to date, the cardiovascular outcomes are established in the semaglutide trials, not yet in the tirzepatide trials. Um, طيب, can we use semaglutide in type 1 diabetes?
I think by the mechanism of action, no.
Yes, there are some studies that showed safety. It actually helps even in controlling reduction of glucose, especially in obese patients. It would be beneficial as well. And I don't think it's a contraindication at all. Um, Semaglutide in underweight patient. Can we use it in a patient who's underweight for cardiovascular disease protection and others?
Oh yes, it does not work only on weight because the mechanism of action is not, the 13% reduction in weight is not the cause of benefit. And if we look at all the trials, the cardiovascular outcome benefit starts from the second or the third week, which is well before the weight reduction. However, if somebody is really underweight, I don't think, we should consider it because it will reduce his weight more.
Yeah, most of the studies had overweight as an inclusion criteria, specifically the STEP HF and maybe for heart failure benefit and benefits. But as you said, the benefit was regardless of the weight reduction. So it's not totally tied to it, although reduction in weight and obesity is beneficial and a target. But regardless of that, as you said, whether it's an anti-inflammatory effect, plaque stabilization, cardiovascular outcomes, kidney outcomes. There are lots of other benefits besides the weight reduction itself. I don't see any more new questions, and I think it
There's
was a
one
very,
question.
very
What's
interesting.
the
Yeah.
most common side effect that appears in patients
Yes.
who use semaglutide for weight loss? I think it's the gastric disturbance. This is the most common side effect, and it's the most common cause of discontinuation of the medication. However, if we look at the pancreatic, the cancer, infection, all other side effects or adverse events, they are less with semaglutide compared to placebo.
Again, it was a very amazing meeting and very beneficial and fruitful, full of discussion and knowledge. I enjoyed having you with us, Dr. Hussein, enriching us with this lots of information. I thank Novo Nordisk for sponsoring such an amazing event. I thank all the audience for being here. If you have any final words, Dr. Hussein.
Thank you, Dr. Walid. Thanks to Kunuz Ritaj and to Novo Nordisk. It's a great opportunity and honor to be with you. I appreciate that. Thank you.
Thank
Thanks
you
for
very
the
much.
audience. I really enjoyed the questions.
Have a good night all. Enjoy.
Good night. Thank you.
شكرا
Allah
لك. مع السلامة.
Hafiz.